Well, thank you for having me. Are you gonna?
Sure, I'll do it. You're like already by yourself. So thanks everybody for coming today. So today we have a very special guest, Dr. Amy Chan from, actually she's triple appointed in both the Department of Medicine, Department of Neurology, and Department of Neurosurgery. We probably know her as one of our neuro-oncologists, and I know many of us here have worked with her on many of our cases, and so she's here to give us some insight into some neuro-oncologic emergencies. So Dr. Chan, thank you very much for coming today.
Thank you for having me. I recognize a lot of names, but not as many faces. But thank you all for taking care of our patients. I know they sometimes could come with mysterious neurological illness, and you're like, what is that neuro-oncologist freaking out over? So this is what I would like to do today. Actually, my world is not that hard. If you're a hammer, the whole world looks like a nail. I really only have a couple of things I can do in neuro-oncology. So once you recognize what's wrong with the patients, there is a method to the madness. And we're going to try to go through three syndromes. Brain herniation, which is essentially the brain is being squished, and cord compression, the cord is being squished, and the mysterious illness, leptomeningeal carcincomatosis with a resorptive hydrocephalus. As you can tell, I want to give you some pearls, how to recognize it. And that's the mental image I want you to keep in mind. Once you recognize what you got, management is kind of simple. You give a boatload of steroids, you can give some anti-seizure medication, and you call surgery, radiation, and us. And between us, one of us should take care of the tumor, right? That's how we do things. Good. I like to keep it simple. And I'll go through some cases. You know, they could look very sick at the beginning, but I think there are hope. So that's why we do this, because we want to recognize it early. So brain herniation. The clinical syndrome is unresponsiveness. But when you think about it, what it is you really have a space problem. There are stuff growing in the brain. Tumors, bleeds, swelling that is pushing the brain out to a point where it is so tenuous where if you just lie the patient down, not draining venous blood out of the brain, it's pushing it over the edge. So what these patients will tell you, you try to lie them down, the next thing they do is sit right back up because the head hurts. Or you try to lie them down, next thing they do is get up and vomit. Nausea, vomiting. And sometimes you would actually see patients who are swelling so much out of the brain that when you lay them down, they'll say, oh, I don't feel so good, doc, I don't feel so good. They pass out. That's essentially pressing unresponsive. And at the very extreme, when you press so much, you start having motor posturing. We hear about that in medical school a lot, but essentially what it means is that if you pinch somebody who's unresponsive and the motor fiber works, it withdraws, right? Or it voluntarily goes somewhere. But if you're cutting off the brain so much that when you pinch them, instead of withdrawing, they push against you. There's only a couple movements the spinal cord can do. The arm can do this. It could do a little bit like this. The legs usually go out straight. And that's what posturing means. You pinch them, instead of withdrawing, it only has one program. It sticks out towards you, and it does the same thing every time. That's motor posturing. That's when you push so much that it postures. And the $1 million question when you have an unresponsive patient always, well, is this opioid overdose or is this brain swelling? And a couple of things you do, you sit them up, see if they do it any better, right? And there's a couple of telltale signs that tell you you're in trouble. Common herniation points, we call uncle herniation. It presses on the third nerve. So one of the pupil get dilated and unresponsive, and it might have some ptosis. When you see that, you know it is not opioids, it is brain swelling. And then you'll see a little bit of kind of maybe the leg on that side don't work as well. When you have the brain on top actually swelling so much that it's pushing down, we call central herniation from top to down. Both eyes are pinpoint, and that's when it's always confusing. Is this just opioid overdose? That's when the motor posturing is really important. You go squeeze them, They might do this, or they might just have this kind of funny tick. You squeeze them, it's like, they do the same thing every time. Or they do this. They do this. That's all they do. Simple program. That's posturing. You know you're in trouble. And of course, when you do the cerebella downward, when you start pushing on the breathing center, that's when you have maybe a little bit more of the Cushing triads. Hypertension, bradycardia, but irregular breathing. That's when you know you're kind of in trouble. But if you have a space problem, what do? It's not hard. Sit them up. The book says 30 degrees. Reason, you want to drain a little bit of venous blood. You want to make sure they don't aspirate. And you want to perfuse the head. But I always cheat. When I don't know, I sit the patient all the way up to 90 degrees. If they wake up and talk to me, I know I have a space problem, right? Because I haven't done anything else other than let the venous blood drain. You want to make sure they're protected in the airway, and you go get a scan. It's a space problem. You should see it. It's not mysterious. And what could you get? A bleed. And there are plenty of reasons why my patient bleeds. We give them chemotherapy, the platelets tank. They could be leukemic, so they have so much leukemia that they have leukostasis. They block off stuff and they bleed. Give them chemotherapy that could make them bleed. And what you do with bleeding? FFP, cryo, same as anything else you do. You can have swelling. What do you give? A boatload of steroids. Dex-10 is always the answer. Start with dexamethasone of 10. And one thing you have to remember about steroids is you give it, it takes about a day to 3 days to come up to maximal effect. So we give it, they usually have a little bit of response, and then the natural reflex is a couple hours later, the patient is not doing any better. And you're like, well, we did everything we could. Not quite. You still need that tincture of time. And then you want to keep the sodium high, so you can never correct people from high sodium. You can't let them kind of correct too quickly when you're low to high, but you can bring them high very quickly. And this way, it sucks out all the extra water in the brain, so it decreases swelling. So you keep the sodium high, and sometimes we give mannitol. That's when neurosurgery and neurologists argue a lot, but we can argue about that. And if you're worried about seizure, answer is pretty simple too. 20 milligrams per kilogram. You can pick Keppra, you can pick fosphenytone, just load them with something. And once you've done all this, you call up neurosurgery, neurology, and we'll have to come up a plan. All those are temporizing measures. So what you want to do is do everything you could within the 30 minutes or so to stabilize the patient. Next thing you want to do is, how do we make more space? If it's a huge tumor, not responsive to anything else, talk neurosurgery into doing something. If it's not something you can get out, you think about getting some of the spinal fluid out, so you make extra space as we wait. So they can do that in the NICU and the EVD. Once in a while, you see a neurosurgeon take off a piece of bone, which is compressive cranial. I have yet to talk a neurosurgeon here to do that yet, but worst come to worst, it's always something you think about. And then once you get that, you think about definitive tumor treatment. Do you radiate? Do you chemotherapy? And that would depend on the tumor. But by this time, I would think all of you have successfully handed the patient off to the next level of care. And you can breathe. They could turn out better than you expect. They really do. So this is a real case. 20-year-old gentleman. He came in for a month of progressive lymphadenopathies, gum bleeding, and he was admitted because his white count was more than 470 and platelets of 16. He was literally hanging around, bored in his room, just waiting for the answer, and they just came back. It is AML. All of a sudden, he was like, oh, I have a headache. Next thing he did, vomited and became unresponsive. What do you think happened? Yep, he bleed. And both of his pupils were small, sluggishly responsive, and he was complex posturing by 4. What do you think he was pushing? Yeah, the top all the way down. Exactly. So he's having central herniation. You go get a scan, and I remember I went down on scan on him, and while we went down on scan, everybody else was getting platelets, cryo, FFP. They were already getting in the weights for the scan. So this is what we see. Hyperdensity, bleed, and when that bled, it goes into the ventricles because it travels down the path of least resistance, and you have blood-filled ventricles. And when you have blood-filled ventricles, CSF doesn't drain, nothing drains, so the whole thing blows up top and pushed out. That's what we're having. And exactly what we said what we were gonna do. We intubated him, we hyperventilate so the blood vessel constricts. We gave him platelets, FFP, cryo, and then once all of those are in, a neurosurgeon went in and put a EVD so you can drain the spinal fluid so it doesn't overflow. And then after that is done, he's still unresponsive in the ICU, but he's not quite posturing. His left side is not as good. And then the neurosurgeon looks at the chemotherapy doctor and says, it's all yours. So the next thing we did was we gave him hydroxyurea. That brings down the white count. We leukapheresed all the white count out. And then I think the second or the third day, we started chemotherapy induction. And he did okay. About a week later, his EVD came out. The left hemiparesis is almost like now it's almost like a hemorrhagic stroke, right? So somebody after a stroke, they will recover some. Recover takes a couple months, and he was limping for a couple months, but he was walking about after 6-7 months or so. And he did achieve a partial remission from AML. Unfortunately, AML is a tough disease, and he didn't take off as good. But so 18 months later, his disease did come back, and it took his life about 2 years later. But we went from near death to 18 months. It's not bad, right? Okay, adjust your expectations. This is Neuro-Oncology. Good. And this case, I try to remember who shared this one with me. Is another real case at Sinai. So he seized, and then one of your residents told you he has unequal pupils. So he's 63. He has a new diagnosis of CNS lymphoma, PTLD. He has kidney transplant that failed, and he basically came back from dialysis unresponsive and has urinary incontinence. And you call neurology to see him. Neurology was like, yeah, I think he had a seizure. You know, one side is weaker, and he's also febrile to 102. So you're like, okay, he has at least 2 reasons to be unresponsive. Do you get a scan? Yep. And why? Aside from me standing here. Unequal pupils, yeah. But most of the time, I make life easy. New onset seizure, don't know why, patient don't look good, get a scan. And this is what we got. When he came back from the scan, you see this pupil. This is his CNS lymphoma. And it's basically pushing over and down. So it's pushing down on that third nerve. And his right pupil became dilated, less reactive, and as the day goes, start doing the whole down and out thing for the third pupil. His right arm looks like this. You know, you try to tug on it, it doesn't quite move. That's what I call increased tone. When you have increased tone, you know that the brain control on the arm is not as good. And we did everything by the book. You got seizures, you get anti-seizure meds. You got fever, you get it treated. And you got lots of vasogenic edema. And this is also lymphoma. You have to remember anything that's the lymphoid disease is going to respond to steroids a little bit. So you're generous. So I think we gave him 10. I was going to give him 4 Q6. Neurosurgery thought I was stingy. So it was like, fine, 10 Q6 it is. And that night I actually had the death talk with the family. I'm not sure whether he was going to wake up from all this. He was unresponsive for literally 24 hours. But by the next day, he was like a new man. He was starting to wake up a little bit. And by around 48 hours, he was awake enough that he can get radiation. You have to follow commands to get into the thing for like that 5 seconds so they can radiate you. and then you can be unresponsive. So we started radiation on day 2, and he did well. The first couple of weeks when we were dialyzing him, they realized that every time they take out too much fluid, he goes unresponsive after dialysis. What do you guys think is happening? He's awake talking to you, but every time after dialysis, he comes like, the brain was swelling so much that just a little bit of extra fluid removal from HD, you could not pump enough blood to supply the brain. So he comes back unresponsive every time they try to do HD on him. So they did SLED. They were like, we'll be gentle on the fluid removal. And we kept him in house for about a month to do the whole radiation. And after that, his cranial nerve palsy came back to almost normal. And he's very deconditioned, but right now I have him on Rituxan, and he's okay. He's home. Alyssa, you probably took care of him, right?
I think I know who you're talking about.
Yeah. Can you believe he was near death?
No, I remember reading this in the text after it happened.
And you were like, nah, this didn't happen. So, see, we save a few lives once you adjust the expectations. Good. So switching gears, the next one I want to talk about is cord compression. The scary thing for everybody. And the thing to remember about cord compression is, actually I want it to be diagnosed early before it compressed the cord. And the thinking of it is pain. That's the key word. To think about it, this is a spinal cord. This is the bony housing that houses. What bones have lots of great things is pain fibers. So when the bones are broken and there are pressure on the pain fibers, it's a painful thing. So cord compression before it happens often is a very painful thing. It could be direct pressure that they said is just that spot when I lie down because you're having pressure. Or it could be kind of off to the side. You know, sciatica is where bones press on those nerves coming out. But now these are nerves randomly on the thoracic spine. But because the tumor is pressing on it, they'll tell you, oh, I have a tight belt feeling wrapped around myself. Or something feels funny. That's often a question I ask people. If you don't ask them, they won't tell you. Where's your pain? It's lower back. They always tell you that. I was like, any tight belt feeling around you? And they was like, yeah, feels funny. That's when you know, scan time. And I became an oncologist because I don't like non-existent things. Oncology, what you see is what you get. You either have a tumor or you don't have one. No magic. Just ask the question and scan. And then the last thing, as you press on a little bit more, as the spinal cord just gets squeezed, but it hasn't stopped working, you have not necessarily motor weakness. What people will tell you is that my legs feel heavy, or sometimes they will say, I don't know, I feel stiff. And when you see them walk, they will be a little bit slower, and then when they take a turn, they fall. So rapid turns, they couldn't do. One guy actually told me, I went to the gym and I can bench 100 pounds slowly. But when I tried to get on a bicycle and do that movement, he couldn't. His legs keep falling off. And the reason is because you think of the spinal cord as a long signal that transmits the motor control. When you squeeze on that cord and it's a little tugged, the signal goes through slower. It's like a faulty wire or a slow computer. You could bench 100 pounds when you're nice and slow, but when you ask it to change movements, it couldn't. So these people, before they get into weakness, they will tell you, I feel stiff. Or when I take turns, they fall. That's what they do. They walk, and then when they take a turn, they fall. And you will also see this in cervical spinal stenosis. Old people with bad neck, right? They will also do that. But for months, my people do it for a few weeks. And when you get that, you get a scan. And that's what you aim for, is to catch all of these before they come into cord compression. So acute spinal shock. When you squeeze that cord until the moment it decides to say, oh, I'm not doing anything anymore. what you get is floppy weakness, hypotonic weakness. Anybody know why I put a picture of the baby up? What does this remind you guys of? Frog legs. Have you ever seen that in an adult? In what cases? Yes, exactly. So actually what happens with the babies is that everything reflexively down the leg, arm and legs are actually controlled by the spinal cord. So when you have a spinal cord injury and cut off the brain control after we become an adult, posture looks like a baby. So acutely it goes into shock, the spinal cord takes over, it flops down like a frog leg pose. And so this is one of the things I teach my fellows when they walk through the ED, when you get called for leg weakness, you walk by and you see, oh, yeah, that needs a scan now. Because normally we lay in bed, right? We can do this, we can do that, but none of us sits there with our legs frogged out. It's an unnatural pose for us. But it's a natural pose if your spinal cord took over. Okay, we're not going into gynecology here, right? Good. And so that's anything that's below that frogged. And the other thing I want you to remember is if you ever have arm weakness and you see the arms being floppy, what do you have to worry about? See 3, 4, 5 keeps the diaphragm alive. And what controls above the diaphragm is neck control. So this is C1 and 2. So whenever I see anybody with arm problems, next thing I check is the head. If the head is floppy, you know you're in trouble. And you probably want to electively intubate this patient before even going for a scan. Because what happens, you lie them down, abdominal pushes up, they could code on you. So call the ICU. And that's acute spinal shock. But they can do okay, relatively speaking. So this is a case of chief complaint was upper back pain. 67-year-old gentleman, metastatic carcinoma of unknown primary. He was at a rehab, and he says that about a week and a half ago, while I was walking with PT, I had this strange pain. And I was like, was it like a band? He was like, yeah, it was like a band, just on this side. He said, I thought I was working too hard. And then a few days later, he was like, yeah, my walking was stiff. My legs feel heavy. I thought, I just worked too hard. So I stayed in bed, literally. And then 3 days ago, he noticed he was having difficulty lifting up the left knee. He still stayed at rehab. And he always had a Foley for urinary retention, so you can't even have that. But the fact that he was missing our appointments, I think I was asked to see him. It was already a scan. I was like, this looks scary. Let's get him to the emergency room. So it took about 12 hours of phone call to get him to the emergency room. And once you get into the emergency room, you see that he lays kind of his legs out this way. And I asked him, I don't even need to test all the formal stuff. I was like, can you bring your knees together? He couldn't. He does not have the strength to bring the knees together. You know you're in trouble. And then I did a sensory level on him, T5 level. And he has some preserved strength, He can flex up the knees a little bit. He can, move the feet a little bit. Actually, his feet strength was almost near full. It was really the iliopsoas that was weak, and that unable to bring the knees together. So this is a partial motor level, right? You know something's off, but it's not 100%. It's not 0 all the way down. And these are the cases you want to catch because not everything is gone. So this is a scan. This is, I always look at, don't let any neurology resident fool you that MRIs are hard. MRI of the spine is the easiest thing. Only pull up the T2 because spinal fluid is bright, so you can see exactly where the spinal cord is. And so this is the spinal cord coming in. You have a little bit of degenerative disease coming in. This looks like a weird bend. Well, maybe he had a lot of degenerative disease, which is what he had. But as we trace down and down, you see it right here. that is pushing back into the spinal cord and squishing it against the dural layer right here, the black line. So that's what it is, cord compression. And in fact, I think neuroradiology does not call this out because for them, they always think cord compression is the fact that the cord got so squished that in the middle, there is edema. That's when they call cord compression on MRI. So MRI scans and clinical syndromes are often separated. And what trumps everything else is the clinical syndrome. So when you call and says, nope, the patient has clinical cord compression, that's it. That patient needs intervention. Doesn't matter what the radiologist says. And this is another look of it. So he had a vertebral fracture with incomplete cord compression. What do you think you want to do with him? Radiate is an option. What else? Steroids. How much? 10. Any other votes? Surgery sounds good. Good. So cord compression probably happens about 5 to 10% of cancer patients. So it happens quite often. And you all take really good care of all our cancer patients, so you will see it. Actually, many, many years ago, neurosurgeons came up with this 100 milligram dexamethasone pulse. That's what they give. And then they give 96 milligrams a day. And if you go to other institutions, you might still have different neurosurgeons on different schools of thought. But there's a systematic review that says 10 milligrams followed by 60 milligrams a day is about kind of maxing out where steroids will help you with. You want to give it as soon as possible, and after definitively treating the patient, you can wean it off. So that's what you do. And steroids, I've done it on a cord compression. I don't remember who shared one with me. I gave her steroids for a long time. Nobody could decide what to do with her. So the steroids effect would last probably about 2 weeks. At around 2 weeks, it starts going away because all it does is tries to squeeze out the edema and it'll come back. So definitive treatment is what you need. So how you pick between surgery and radiation? The answer is kind of simple. The surgeons always get the pick. They always like the good-looking ones. And also it's big surgery. So if you think about it, if the patient is not going to live more than 6 months, you might not want to put them through a big surgery. So that's criteria number one. Are they going to live more than 6 months? And then the second big criteria is it just one layer of involvement or multiple layers of involvement? If you're going to put a patient through surgery, you fix one place and then the next place is going to give you trouble, or there's just no way you can fix so many places, then you know it's not a good surgical candidate. And if the patient is already paraplegic for more than 2 days, you're not going to gain anything. So they're not going to take it to surgery. So the idea is you want somebody who's good looking. Once in a while, they make an exception if it has poor prognostic factors for radiation. What does that mean? If you have a vertebral compression, radiation is not going to fix that. So the radiation oncologist will tell you, sure, I can radiate, but I'm not going to fix anything, right? Because it's a fracture. So that sometimes they make an exception. And if they're not going to live long, you can radiate once, big fractions, 2 days, or 8 days. Nobody really knows what's the right answer, but it's just a few big fractions and you're done. And it does help with pain control, keeping walking, and keeping urinary continence. So that's what we do. And so at the end of the day, because he had a compression fracture, he went for surgery. Don't know whether any of you took care of him. I think he went over to family medicine after surgery. Unfortunately, his prognosis was pretty poor, and he's, not very good looking, 67-year-old. He died of complications about a week after surgery. So it's not the best, but this one, it's a better one. He's 50. He has metastatic colorectal cancer. He decided to stay on alternative treatment. And he was only on pain management. They went to pain management and was like, I have this new lower back pain. It starts, he says actually, it starts in the middle here, and then it kind of wraps around the back. When he goes to bed, the pain was so bad that he has to get up and walk around. And he felt like he was a little stiff. What do you think he's describing to you? He has this belt-like sensation, and when he goes to bed, it hurts so much he gets up and walk around. Yeah, kind of compressive, or at least neuropathic pain. I always tell my neurology residents, you want to distinguish, is this musculoskeletal pain or is this neuropathy pain? People who have stretched muscles, who has musculoskeletal pain, they don't want to move. That's when it moves. So they would lay very still and very comfortable, thank you very much. But patients with neuropathy, sciatica, it hurts so bad that they will keep trying to move around to find a good, comfortable position. So that's tip-off number one. This is neuropathy pain that he's having. He won't even sleep. He was up pacing. And his gait, he was saying, was a little stiff. And he came to the ED that morning because he had a strange sensation of tingling down the left leg. It feels tinglish. And he couldn't get out of bed. And then eventually spread to the right leg. And in the ED, he had a partial sensory level. His motor was actually pretty good. His leg was in neutral position and had pretty good strength to confrontation. But he has urinary retention. They put in a Foley in. And that's the other sign I tell my fellows. I was like, men never begs for a Foley. It's a great sign, right? It's a sign of something's wrong. Urinary retention. Men never begs for a Foley. And in fact, he came to the ED, he said he couldn't get out. And then the next 3 notes is, I'm begging for a Foley. And that's what he had. He had epidural compression. So this is the bone. This whole soft thing is extra tumor. So the tumor has crept around into where the nerve root usually comes out and comes in and literally wraps in and choked the spinal cord. And these two are the nerves that sticks out. So he actually got decompression, and he's, oh, never mind. He got multiple level disease. These are all part of his tumor. And he has multiple level involvements. He got hydrosteroids, and in retrospect, I would have radiated the man because he had a couple level of involvement, and it's colorectal cancer, which is pretty sensitive to radiation. Unfortunately, we decompressed him, and he was pissed off at us, and he didn't want radiation afterwards, and he compressed later. So I changed the story. Make sure nobody hears this. All right, good. Questions about the first two? All right. Leptomeningeal carcincomatosis. A vote for people that think this is a mysterious thing. Everything got called as lepto. And going through 4 years of training as a resident, that's exactly how I felt. Everything that's strange, unexplained, it's lepto. It's possible because it has a lot of manifestation, but let's define what it is first. So leptomeningeal carcincomatosis literally is that the tumor is in the spinal fluid, okay? And then what I want you to imagine is a dirty swimming pool. That is what it is, tumor, and our spinal fluid is a big swimming pool. And what happens when your nerves is in the dirty swimming pool? It's not happy. It doesn't work. And there is gravity to dirt. So dirt accumulates the bottom of the brainstem, the bottom of the spinal cord. So the cranial nerves, anybody remembers what the fifth nerve looked like? This is the bilateral fifth nerve. It sticks out, just like 2 hands waiting for dirt to collect on it. Actually, one of the most sensitive early signs. People tell you that the face is numb, and there's a patch here, there's a patch there. Actually, they will tell you it's tingles. One patient told me, I felt like there's ants crawling on my face before anything happens. Usually what brings them to attention? Ptosis. When eyes get droopy, then people pay attention. And then facial weakness, and as they drop down to the 10th nerve, hoarseness of the voice. Cerebellar dysfunction is kind of hard to pick up. But you see the sense what I'm talking about? We're talking about dirt collecting on the bottom. That's what it is. And then if it goes lower down, quadi equini. That is the literal translation of the spinal cord. It's the horsetail. And in leptomeningeal carcincomatosis, when you have so much tumor, the horsetail get coated with tumor. And the sign of it is when you look at a T1 with contrast, you should never see that thing light up. When you can see your horsetail, you have tumor. 80% of the time. And what they have, these people will drive you crazy. Remember we said that people with compression, they have one level of pain, right? Well, these people have literally tumor that's swimming and touching every nerve that's coming out. So what they could have is, I have pain running out here. I have a patch of pain down here. I have a patch of pain here. You're like, what are you talking about? And these pain comes and goes. Imagine you're the tumor cells floating around. You go touch this nerve, and then you go away and go touch that nerve, and you go away and you go touch this nerve. And anybody have sciatica before? How painful is it? Very. Makes you cry, right? Well, you're still awake. Yeah. Well, imagine your sciatica runs from here, up to here, over here, and it just runs around. And you don't know what's happening. That's what's happening with patients with leptomeningeal carcincomatosis coating radicular nerves, what I call radicular pain. And then as it coats more and more, you get the quadi equina syndrome. You get the numbness, you get the fact that you couldn't push urine out. And that's one of my favorite early questions. Any numbness in your private area? One patient once told me, it feels like a tampon stuck down there, but there's nothing. It feels strange, spongy. Remember the ants on the face? Same idea. Nerve pain. You ask them, when you want to go to the bathroom, can you get started? Or do you have to push a little longer? And people with early urinary retention was like, the last week, I just have to push for 5 or 10 minutes before it comes out. There's something. So that's one syndrome of leptomeningeal carcincomatosis. You can understand why, everything kind of get blamed on it, right? And then the second syndrome is what I called aresorptive hydrocephalus. David knows this. And the way to imagine this is that your swimming pool is so dirty that the drainage get clogged. So you essentially have a clogged sink. And when you look at MRI, the radiologist can never read it. Because what are you looking for? You're looking for these ventricles just subtly getting a little bit more plump. The brain doesn't like changes. It's a limited space place, right? You get space occupying push, doesn't do well. And what do people tell you? First thing, when they lie down, they have headaches, recumbent headaches. Next thing they tell you, it's strange. Every time I turn, the world moves. Imagine your sink is a little overflowing, you turn, a little splash. That's what they tell you. And then the next syndrome is wet, wobbly, wacky. What is that? Yes. Except in my case, it's not normal pressure because it's clogged up, right? So you have a little extra pressure. But the idea is the same thing. And the wacky part is actually very specific. It is What's your name? Amy. Very slow. An interview could take you 2 hours. But if you have the time, which I've tried, the patient is actually usually oriented 2 to 3. They're not bad. They can tell you who the president is. You just have to sit there for a long time. And the reason is because, remember earlier I told you about the pressure? So the brain is under a little bit of pressure. So signals is running very slowly, but it's still there. So that's the whack of NPH. We shared that lady. She was ANO times 2 or 3, right? You just have to sit there for a long time. So that's the wacky. And the wobbly is what we call gait apraxia. And now I'm beginning to appreciate them more. You sit them up. First thing, they have very difficulty kind of standing themselves up. They look a little bit like the Leaning Tower of Pizza. And then the next thing, you ask them, take a step. And that leg looks like it's stuck in mud. They couldn't pick up the step. So this is worse than the cord compression people. They couldn't initiate anything. And that's the gait apraxia, stuck in mud of NPH. That's the wacky. And wet. The micturition center is right at the inferior frontal lobe. So when you have the pressure, they press on it and they just have urinary incontinence. Except in my patients, if they have lepto, they might have urinary retention. So you're a little screwed one way or another. But that's the syndrome. And when it gets really bad, because it's not normal pressure, the pressure is building up so much, it just press on things far enough, they would actually pass out. And the story of them passing out is they'll go from sitting to standing, and once they stand up, because there's so much pressure up top, you're not perfusing the brain. They pass out, syncopize. And it's always being called, oh, is it a seizure? Is it something like else? No, it's just literally pressure. So they could stand up, pass out. They could lay down and pass out. One lady gave me a very good story. She says, I was lying, and then all of a sudden I have a wicked headache. And the next thing she says, because I have a headache, I try to get up. So she tried to get up. She stood up, passed out on the floor, and vomited. And then while you found her on the floor, how are you doing? She was like, you know what? I'm feeling much better now. Talking great. She was like, I don't know. I have the bad headache. I vomited, and now I feel great. She was backing up so much pressure. She stood up. She couldn't perfuse, went out. She vomited, and things equilibrized, and she feels great. These people are wacky, aren't they? But that's the time when you know you're in trouble, because if these pressure builds up long enough, and one time they don't wake up, that's sudden cardiac death. That's sudden death. And I had one patient whose pressure built up to 40s or 50s, sitting there waiting for an LP and coded. So that's when I got David really excited. All right. 2 cases. How am I doing on time? Okay, good. We'll finish the last 2 cases. So this is a very typical case, and her chief complaint is pain. She's 59. She has hormone positive, HER2 negative breast cancer, and she had completed her therapy. And before she showed up at Mount Sinai, she actually had like 3 ED visits for complaint of pain and discharge on a little bit of opioids, and then later opioid seeking. And she finally arrived at, when you go and ask her, and she finally arrived at Sinai because one of her eyelid was a little droopy. We decided to admit her. And you go ask her a story, and she says that about a month ago, she was having so much tingling in her hands, feet, that she stopped her medication. She thought it must be my medication. And then 2 weeks ago, she's morbidly obese, instead of using her usual cane, she just started using a walker. And she came to the hospital because she was barely able to get out of bed. When you examine her in bed, she has full strength. And then about a week ago, she started noticing that the eyelid was a little droopy. And then once in a while, she has double vision. And if you ask her really carefully, she will say, yeah, it feels not quite normal down there. And over the last week, I have to push more to pee. And now the pain, not just in the hands, it was also kind of migrating in the arms and in the legs. And that is what she really cares about. And that is also what brought her to 3 different EDs until the ptosis caught our attention. I like to say we're better doctors. We admitted her. And what do you think is happening? Yes. Specifically in brain and where else? Yeah, leptomeningeal. So you examine her as kind of what you expected, a couple cranial nerves, a sensory level. And I actually think her clinical diagnosis is suspected leptomeningeal carcincomatosis because she has multiple cranial neuropathies, she has quad equina syndrome, and she has multiple radicular pain. That's what I think her clinical diagnosis is. And this is a case where you all's clinical acumen is going to trump anything the radiologists read. So this patient was actually on neurosurgery service for a couple of days. No oncologist got called, no neurologist got called until neurosurgery looked at it and was like, I don't think this is, I'm operating on it, transferred to medicine. And then medicine called oncology and I got called. What they had was, neuroradiologists initially thought, oh, this looks like a little hump. Don't know what that is. And so they says there's a fullness in the right cavernous sinus with post-contrast enhancement. But what they were not paying attention, because nobody told them that the patient has ptosis, is that these 2 are cranial nerve 3s that's coming out right in between the vessels. It's lighted up, it's coated. This is where 4, 5, 6 goes through the cavernous sinus. And if you look carefully, the 7th and 8th nerve also looks like it's being coated. So after I see the patient with the oncology fellow, we're like, and medicine was like, yeah, something's up. We asked for an LP. And then after we asked for the LP, the radiologist goes back and then their note and says, further review revealed that there were multiple enhancing nerves. And in fact, that's what she has. The tumor, the pathology is in the spinal fluid, right? So we'll take a little sample and hopefully we find it. And we did. There's 7 nucleated cells. That's what WBC means. 3 of them are others. That is her breast cancer tumors. And you got lots of debris, right? 175 of protein. And glucose, as it gets bad, it'll come down. But that's what she had. And I like to say that it's good to recognize the syndrome because leptomeningeal carcincomatosis is so hard to recognize. Very often, by the time anybody discovers what it is, all the literature quotes median overall survival, a month. They progress. They progress typically over a few weeks. If you missed it the first time, a couple EDs visits later, you're 2 weeks. And you're hitting right up against the median overall survival. And treatment for anything that's neuro-oncologic is, I of course hope to bring things back, but often you just preserve what you have. So you want the patient going in the best looking state. And what you want to do is you want to treat the entire swimming pool. You want to treat the thick enhancing disease and the circulation dysfunction. That's what you aim to fix. NCCN tells us you can radiate wherever that's symptomatic. So if you have cranial neuropathies, you have bad circulation for the brain, you radiate the brain. You got quad equina, you radiate the quad equina. You get some really bad pain area, you radiate those. That's spot welding, radiation. And then the next thing you need to do is make sure a chemotherapy doctor comes along and tells them, guys, we caught this early, your turn, okay? Because you can't just treat an entire problem with spot welding, right? So CNS active chemotherapy is what you want. Intrathecals, I'm often asked about it, but actually the data is not there. I think it's been done for many years because we're doctors and we want to do things to make us feel better and feel like we're doing something. This is the best data I find in breast, actually. So this is 182 patients in the United Kingdom for 10 years. What you have on the line, the very bottom, is hospice care only. You see median overall survival, short months. This dotted line is intrathecal chemotherapy. It's almost lying over hospice. Because the problem of injecting chemotherapy into the brain is that you can never inject enough to sterilize the whole swimming pool. And a lot of the tumors that's in the CSF is not sensitive to the stuff we can inject there. So we make ourselves feel like we're doing great, but we're not necessarily fixing the problem. And if you imagine you have a circulation problem, you don't want to be injecting chemotherapy there until you fix the circulation problem. And then this line is for radiation only. And then see this line here is radiation and chemotherapy combined. And I want to point out the median overall survival here. This is breast, but still, it's over a year. So we could give these people months of still preserved neurological function and some life. So not all hope is lost, right? All right, last case. This is David's case. And her chief complaint was literally passing out upon standing. She's 52, 10 years of breast cancer. Over the last 3 weeks has been complaining of progressive headaches and dizziness. And if you go ask her what the dizziness was about, she will tell you that, oh, every time I turn my head, the world is just all over the map. That's her dizziness. And the very first admission she had, she got an MRI because of the symptoms. And they found a met, 1 centimeter. I was like, okay, that looks good. We'll get radiation to SRS that dot and we'll be all solved. Do you think that's giving her the 3 weeks of headaches and dizziness? Mm-mm. And in fact, she went home, didn't do very well, went to her oncologist's office, was having these headaches. She's starting to prescribe her more opioids. And as she was leaving the clinic, she stood up and poof, she passed out. That was how she landed in the ED. And that's the history we got as we were talking to her more. This intermittent orthostatic syncope, and then intermittent double vision. And just, she's a sharp lady, but she was just like, I feel confused. Does demented people ever tell you I feel confused? What she says is, I just feel like it's taking me extra time to think. Very eloquent, right? But she was slow. She was wacky. And the biggest thing you know is you asked her, so the headaches, is it waking you up from sleep? And these people will start telling you, yeah, I couldn't sleep for more than a few hours. Wake right up because the head hurts so bad. And then, well, she can't sleep and she can't stand without passing out. Sounds bad, right? And she has a little bit of clumsiness in her hands, just icing on the cake. So, and in the ED, she was having hiccups. She was moaning in pain. That's what these people are. They moan, they're in a lot of pain. And she really was not in the mood of talking to you. What do you think the hiccups is about?
Cervical.
Could be cervical, but a little higher up. The fourth ventricle. The vomiting center is also a hiccup center. When you have enough pressure on it, you got some brainstem symptoms. They won't stop picking up. It's also another sign of we're in trouble. Cervical could too, but you could do it a little bit higher up. And that's what she had. I suspect she had leptomeningeal carcincomatosis with aortic hydrocephalus, cerebral compression because she can't think, and brainstem compression because she was hiccuping. Not good. But if you lie her at the magic 45 degrees and do not move her head, she's okay. And on imaging, it's very, very subtle. Actually, now you don't even see the nerves being coated. It's all pressure. And when you have pressure, all you have is a little pressure against the leaflet. So if you imagine kind of like a fold or your finger fold, you just press it a little harder and you just see that fold a little bit accentuated. That's all you see on imaging. And radiologist has a hard time calling this, and it has to be a clinical diagnosis because the clinical diagnosis is actually staring at you in your face. And because her pressure was so bad, we needed to radiate her, and there was heated discussion about how do we keep her from dying on us suddenly while we try to unclog the drain. We thought about putting in a drain, but are you going to put her through surgery? And that drain could clog too. So the compromise was, let's do daily LPs to unclog the drain. And if we don't survive that, we'll put in a shunt. So David coordinated over a weekend, multiple days.
I just threatened the neuro resident that we would transfer to their service. They didn't help us do the LPs. Then we got their help.
And the first day, the opening pressure was greater than 36. The patient that died on me, her pressure was in the 40s and 50s. So she's getting close. They drained out a bunch. There's just a couple cells, some protein, and then each day we're coming down. And after about the second radiation section, her headaches improved. And if she doesn't move, the world doesn't spin. And we kept her out of the hospital for about a week. She was able to walk around a little bit. Unfortunately, it's really, really bad disease. We did start Xylota, like almost right away after radiation. And a few weeks later, she came back to the hospital. And this time, it's not headaches. It was diffuse pain everywhere. A nurse would try to clean her, and she would cry because just the touch was excruciating. So she went hospice, and she died pretty soon afterwards. Good. So we won't do this one. And I hope I gave you some colorful clinical syndromes, and it's not too bad. There are things we can do. If you suspect somebody have herniation, they're passing out when you lie them down, you sit them up. Make sure they're protected. There's a bleed, you stop it. If there's a seizure, you stop it. You make space. Bring in your drills. You treat the edema and you treat the tumor and you hope for the best. Cord compression, the warning signs in clinic when you have a tumor patient or anybody, always ask about the tight belt. Always ask about the stiff gait. You might pick up a cervical compression at one day and leg heaviness. People never say I'm weak. And when you walk by the ED admitting somebody who the ED, of course, meticulously examined, you see the frog pose, you get an MRI. You give them Dex, and then you go get an MRI. And then radiation and surgery can duke it out. And leptomeningeal carcincomatosis, that's really, really a clinical diagnosis. And I rely on all of you to recognize it. Once you recognize it, it's actually really easy. You know what the problem is. You treat, and you hope for the best. But the first step is recognizing the problem. Cranial nerves, remember the ugly duck, radicular pain, wet, wobbly, wacky. Never forget. And do the LP. That's where the tumor is. That's where the diagnosis is. And you can be therapeutic and drain it down the clog. And you radiate and you do chemotherapy. Questions?
I have a question. You gave us a lot of great exam findings and things to ask about history. So, as far as from your perspective, what's for us in medicine, what's one thing we can do ourselves or tell our residents to do as far as a neuro exam for these patients that's so important? Besides, a thorough neuro exam, but what are some of the things that people miss that
Things are new. Things are new. Like neuro exams, I think a lot of neurologists pride themselves of 60 different Greek eponyms and these crazy maneuvers, which I don't even memorize. But if you actually ask in history, they will tell you where their problem is. So If they're telling you something, that's new and progressive over the last week or two, you harp on that and you think about it from our thing. Is it cranial neuropathies, right? If you feel like, hey, I got a little droopy eyelid, you go for all the cranial neuropathies as a cousin. And then you're thinking about leptomeningeal carcincomatosis. So you ask for all the rest. So the cousin pieces. So that's one for leptomeningeal carcincomatosis. For space occupying things, the history will tell you the recumbent headaches. And the mental status, attention is going to tell you the best. That they're a little bit kind of like decreased. I would say for medicine, if you know what you're asking for, and you kind of get a history and says, I got these things that are this package. 2 weeks ago, I have this. A week ago, I have this. A day ago, I have this. You'll get somebody's attention. And you can start, localizing it. The exam is just there to verify what you're suspecting a problem is. So you think a problem is up here, examine everything in the surrounding. Your problem's down here, examine it down here. It's that pattern recognition. I really don't think the neuro exam needs to be all the pinprick, the whole sensation thing. You ask the questions, you actually see how I do an exam. I ask the questions, spend 30 minutes asking questions, 10 minutes doing the exam. Because the history really tells you where the things are. Make sense?
Well, if you have any questions, feel free to talk question after, but I think we'll wrap up now. Thank you so much for your answers.
Thank you for having me. Sorry, I ran over time.
I don't know. Do you recall, back during the case, do you recall that, I don't know if you were aware of this, the pathologist who examined the CSF sent me an email saying that the cells that were malignant in the CSF weren't consistent with breast cancer. Yes, that's what, sending the email that cells weren't consistent with breast cancer, making me think that there was a second CNS primary, which I was like, that's insane. And she was like, well, get me another sample so I can take a look at it. So after the next serial LP, she'll look at it again, and she's like, oh, okay, it's breast cancer. And I was
The problem is it was so malignant, it looks funny. That's why CSF diagnosis is so hard. And then it has to be a clinical judgment.
Yeah, but the pathologist, she said, she's like, this doesn't look like breast cancer cells to me. And I'm like, oh my God, is there CNS lymphoma? Like, what's going on here? Like,
it's okay, the treatment is still radiation.
Yeah, I was like, how can there be two primaries? But there weren't, thankfully.
Yeah. Thank you.
That case was already crazy enough for me, and then it just got even crazier. So
you didn't even tell me that.
Well,
it
happened in the space of like 24 hours that she was like, this doesn't look like breast cancer, get me another sample. And we're like, I have another sample, here you go. And then I was like, okay, it's fine. Otherwise, I would have definitely been like, you need to deal with this.
Hey, how are you?
We're good.
How's you?
I know.
We've been in email so much that we had like several patients together.
I knew you were going to talk
I know.
Okay.
So just to let you know about Mr. LeBron, who's on KCC5 right now. We're waiting for rehab. There's some acute rehab that's interested, so we'll see if they can, So just to clarify, this chemotherapy, if he stays in the hospital, he can't get it. So he has to leave, And this is not something we want to wait. Meaning, the social worker asks, can he, let's say that's a barrier, can he go for a couple weeks and then get it? No. We just try to do it ASAP.
He's already due this Monday.
Yeah, I know that's why they're applying to both SAR and acute right now. But the other thing, just so you know, the palliative care social worker and NP has spoken to him now for a couple days, and today, after a lengthy discussion, he talked about never wanting to be intubated.
That's good.
So we're gonna do the most in the DNR DNI, just so you're aware. Yeah.
He's not doing well, and he's gonna crash.
Yeah.
That's why I'm not even picky about like the acute versus SAR.
Yeah.
What we do, rearranging the vectors here.
How long do we think with the chemotherapy? Like
It's
what?
gonna have.
Yeah.
So Avastin is there was a controversy earlier when me and Adelia had a case. So Avastin, the clinical the data that's out there for relapse disease, progression-free survival is only on the order of a few months. And the overall survival And when I say a few months, I say
Yeah.
like 2, 3, 4 months,
Okay.
kind of that. And the overall survival is probably going to be, 6, 7 months or something. Like
Okay.
that. He just started Avastin.
Yeah.
Now, I still do that because A, I don't have a lot of hammers,
Yeah.
and B, there are patients that miraculously, for whatever reason,
Yeah.
is very sensitive to Avastin.
Yeah.
And my mentor and
Yeah.
anybody who's practiced long
Yeah.
enough would have these miracle cases that lives a year, 2 years, 3
Yeah.
years with Avastin. So you don't know.
Yeah.
You don't know who falls into that. Maybe
Yeah.
5% of case that does really well.
Yeah.
So you just give it and try.
Yeah.
The key about Avastin is performance-free survival.
Mm-hmm.
He's on a lot of steroids, and that's because it's very close to his motor area.
Yeah.
So I wanted an Avastin to kind of curb it
Yeah.
back a little. He already have wicked motor, like what do you call it, steroid myopathy.
Yeah.
So
He, just so you know, is still very hopeful that he will become cancer free. He's still.
his wife knows. I don't know how much he knows. Like I
Mhm.
used a translator to the wife.
Yeah.
I gave the numbers before, but I don't think he really.
I don't think he's. Yeah.
But DNR DNI is good. Thank you.
Yeah.
Thank you. I'm sorry that I stuck him on your team for placement. If he's giving trouble, you can always transfer them later.
Do you remember when we had Miss Perudo? Do you remember? Yeah. She's the one, I think she had breast cancer.
She's one of the pictures.
Oh,
You called it.
yeah, but then she's the one that that you said that the radiologist is that.
Yeah.
Yeah.
Yeah. And then they went on a note.
Yeah.
Yeah, because they just. Oh no, Bruno was about this, but it was the same thing.
It was
They missed
similar.
it.
Yeah.
I missed it because
Yeah.
they can't diagnose it.
She died? I didn't know that.
So, what happened? She already has COVID radiation. She's
Yeah.
not eligible
Yeah.
for any more radiation. So they tried to give her chemotherapy,
Yeah.
but her outpatient oncologist was not going to give her chemotherapy.
Yeah.
And then one, she was deteriorating. What did they have? She had
Uh-huh. Intracranial.
I think she was both intracranial and
Uh-huh.
and she had to go to. She has triple negative. Yeah, exactly.
Oh, boy. All right.
Thank
Thank you so much.
No, thank you for having me. Or do like